morning, ladies and gentlemen. Thank you, Mr. Chairman. I was given the task to address you with respect to the device registry in Saudi Arabia, what we have learned. What we have in the Gulf area, which is Saudi contributed quite substantially, is to the Gulf ICD Registry, which represent mainly the Saudi experience, which is about 70% of this population are from Saudi Arabia. So that's what I'm going to present in the coming 20 minutes or so. This work would not have been possible with a great collaboration with my colleague who actually made this possible. So I am presenting this work on behalf of our colleague from the Gulf and as well as from Saudi Arabia. I'm a co-PI in this registry, and there's most of the implanting centers in Riyadh or in Saudi are heavily represented here as in the steering committee. By way of background, device implantation from the guideline, which informs us what to do and how to do things. However, guidelines they don't inform us about what we do on a daily basis. So here comes the importance of having a registry which tells you about your population, what is the uptake of the guidelines, and what's the adherence to the therapy. Unfortunately, there is a very scarce data when it comes to device implantation in this country. The only paper that was published in 2010 was a single center study from our hospital, and in that registry, in that study, we learned that there's about 120 in 1 year implantation in our center. Most of the people who had ICD were younger than their Western counterpart. 50% ischemic heart disease and 50% were DCM. As well, we learned that the majority of patients who had ICD implantation were due to primary prevention. There was a couple of abstracts presented in subset of population like Brugada syndrome by Dr. Dawla. Then Dr. Alawi Sheikh for Imam Emirates presented his a survey from the UAE looking at the pattern of uptake of ICD implantation in the Emirates. Najib al-Rawahi also presented an abstract about indication of cardiac device implantation in Oman. So that's the only the information we have on ICD implantation, population, and uptake and adherence to the guideline. Therefore, we opted to go for a full-fledged ICD registry across the Gulf countries. This registry is a prospective, observational, multi-center, national study of characteristics and outcome of patients receiving de novo implantation defibrillators in the Arabian Gulf country. Original enrollment were 1,000 patients. In over 18 months, we increased the enrollment to 1,500 patients. Data on baseline characteristic, ICD programming, parameters, inpatient outcome and complication, as well as we're collecting data on long-term mortality after 1 year and incidence of shock in these patients. And the enrollment has been completed in July of 2015. The follow-up will be complete, the 1 year follow-up will be completed in July 2016. Inclusion criteria, we included all de novos, ICD or CRT implantation, in patients aged more than 18 who agreed to sign informed consent. We excluded battery changes as well as younger patients or even anybody who refused to enroll in the registry. To have a meaningful interpretation of the outcome in terms of mortality and shocks, we had to calculate a sample size. We made certain assumptions. We assumed that the event rate will be 10% with a margin error of 2% and 95% confidence interval. That gives us 129 sample size. To account for loss of follow-up or dropouts, we increased the sample size to 1,000. Eventually, we increased to 1,015. So that's our target sample size. With an error of 2%, we needed about 1,500 patients over 18 months. We used the ACC HRS guidelines in terms of definitions and diagnoses and data collection. We used the NCDR CRF format. This is the timelines of our registry. The first enrollment happened in January of 2014. The last patient was enrolled in July 2015, and the follow-up will be complete in July 2016, inshallah. Just to give you a glimpse of our electronic CRF, it's quite extensive. Just in the first few pages, we talk about patient demographics, disease burden, and what have you. And then in page 7, there's an ICD programming in order to capture the pattern of practice and how the ICD were programmed in different zones and different practices in the area. Also, we capture adverse events, whether it's in-hospital adverse events due to implantation or after discharge from the hospital. Also, we capture a follow-up at 1 year, rate of ICD discharges, as well as mortality or any other symptomatology. Also, it's captured in the CRF. We've published our methodology paper recently in Heart Views, which explains the whole project, and this was published a few months ago. This is the centers enrolling. It represents 6 countries and 15 centers, mostly the centers who are high volume implanters. I think we missed few centers which are small centers, but I think in general this represents 90% of implanting center in the region, especially in Saudi Arabia. You can see that most of the big centers with EP programs are represented here. The only people who are not represented, which is the private sector. However, this is a very small proportion of implantation. In UAE, there's 3 centers implanting. In Kuwait, 2 centers. In Oman, 1. Bahrain, 1. And Qatar, 1. So prior to the enrollment, we conducted a survey to look at the service provision as well as the pattern of practice in these hospitals. And this will put things in perspective when you interpret the data. So we surveyed all the centers. We asked, do you have a dedicated EP laboratories? And 2/3 of the centers in our region have that dedicated EP lab. If yes, how many? And most of the time, it's only 1 lab in the in the hospital. If there is no, where do you put your ICDs or implants? And majority said in the cath lab, although if they're not dedicated. We asked the question, who implants? And the majority in the region of the devices are implanted by electrophysiologists. There's only 1 center who has a non-EP doc who's implanting devices. How many implants routinely implanted, carried out in your center? And the average is about 2 to 3 per day. And how long have you been implanting? And the majority of implanters have been in business for the last average of 10 years. This is the answer to the question, how many ICDs do you implant per year? And as you can see, if majority of them, they implant about 100 to 150 a year. There's small centers, and this data is skewed due to have small centers from the Gulf region. But if you look at the pattern in Saudi, I think the 27% represent the average volume of implantation per center. This is the answer to the question, what percentage of your ICD implants are generator change? And it very coincides with the literature in the Western world that 70% are de novo, 30% are battery changes. So about 30% to 20% are battery changes in our practice as well. The question, do you perform DFTs, which is defibrillator testing? And as you can see, never or rarely is about 90% of the time we do not perform DFT, and that's also coincides with the practice worldwide. Nobody does DFT in a routine fashion nowadays. Do you use remote monitoring? And it's quite interesting to see that the uptake of remote monitoring in this region is quite dismal. About 90% of the population that had ICD, they don't use remote monitoring. Which ICD manufacturer do you do? This is just to look at the market share of each vendor. And as you can see, all the centers who implants ICD, they use Medtronic on top of others. Then St. Jude is used by 13 centers, and Boston Scientific 13 centers. Only 10 centers out of the 15 centers that we surveyed use Biotronic devices. This is to show you the enrollment rate and the enrollment rate per month. We started January 2014, and we finished enrollment in July of 15. And the average enrollment per month is about 88 devices per month. There are certain months that we have higher enrollment than others, which explains by holidays, religious holidays, as well as summer vacation, where you have services slows down quite a bit. This is the number of implants per centers, and as you can see in the bottom of the slide, Prince Sultan Cardiac Center is the highest implanting center in the region. And then followed by Prince Salman in Saudi Arabia. And if you look at the total percentage of implantation, you can see that 70% of the 1,545 patients that implanted over this period was implanted in Saudi Arabia in green, 71%, and the 30% was in different Gulf countries, and UAE being the second largest implanter after Saudi Arabia. If you look at the population, this discrepancy in volume makes sense because the population of Saudi Arabia relative to the population of the entire region is the highest population in the Gulf region. It's about 60% of the Gulf population are Saudis, so that makes a lot of sense that we implant more than other neighboring countries. So this is the baseline characteristic and demographics on the left side of the screen. The right side of the screen is the American data for comparison. As you can see that out of the 1,500 patients that we've enrolled, the average age of implantation in our population is about 57 compared to 68 in the Western or the American data. That's quite small. We're about a decade younger where we implant ICDs, which has a major implication in the socioeconomic and health provision and burden on the healthcare system, that you get a younger population, sicker population with multiple risk factors, they're needing ICD. Just you can imagine how many of those will need generator change, device complication in the coming 20 or 10 years of their life. Male predominance, 83% of the population are male who had an ICD. And economically, if you look at the US data, Medicare provides 60% or 67% of the incur the cost for ICD implantation. However, in our situation, it's a governmental agencies which pays for the cost of the device as well as the operator. If you look at the comorbidities and ejection fraction, mean ejection fraction in our population was 27%, and 89% of the population had an ejection fraction less than 35%. Predominant risk factor diabetes, 57 compared to 30% in the Western population. Hypertension, 62% are hypertensive, 70% have history of heart failure, prior MI. So quite prevalence of major risk factor for coronary artery disease as well as risk factor for stroke in terms of atrial fibrillation. If you look at the reason for implantation, 80% of the time the reason for implantation was primary prevention. Elective admission in half of the time. Pre-implant EP is very small, and that's really reassuring to see because you don't need most of the time EP study to implant ICD. It's very rare occasions. DFT testing 4%. If you look at the type of device that we implant, ICD single versus dual, it's very also reassuring to see that the majority of the patients who need ICD, they use single chamber ICD.